Let's talk about depression in later life. I'm Dr. Nicole Didyk, and I'm a geriatrician internist. I've looked after older adults for about the last 20 years, and I've seen a lot of people with depression. In this video, I'd like to talk a little bit about what makes depression different in older adults. We won't talk too much about treatment. We'll have another video about that. But let's talk about depression and how it's diagnosed. Many people think that older adults are naturally going to feel depressed because of the many changes and losses that go along with aging. And I can understand how people would think that. But actually, the incidence of depression in older age is probably a little bit less than that of the general population. But it depends on which group of older adults you're looking at. Just in general, the incidence of depression is probably around 2 to 5%, and that's in older adults. And in the general population, it's closer to 6%. But if we look at older adults who are recovering from heart disease or stroke, then the incidence of depression is about 40%. And of those in hospital, older adults in hospital, about 30% would meet the criteria for a major depression. So in some groups of older people, depression is quite common. Older adults are more likely to have some unusual features of their depression. So they might be more likely to have physical complaints. They might be more likely to have anxiety. About 50% of people living with depression who are older have anxiety, significant anxiety disorders as well. Older adults might also they might just show up as being less motivated. So, for example, if somebody is in hospital and they're doing rehab, but they're not really interested in it and they're not really progressing, well, that could be a sign of depression that you might be sort of atypical. So it's really important to be aware of depression and to kind of look out for it in older people. But the criteria for a major depression is the same, regardless of the person's age. So the one that I use and that a lot of people use is the DSM-5, which is the Diagnostic and Statistical Manual of Psychiatric Disorders, and that's the 5th version of that. You have to have low mood, like sadness, or you have to have loss of interest, which is called anhedonia. So basically a loss of interest or loss of pleasure, more specifically in activities that used to be pleasurable. So you have to have low mood or anhedonia. And it has to be a change from before. So you can't just sort of be Eeyore, who is never happy. It has to be a change. It has to be present for at least 2 weeks. And it has to kind of get in the way of your day-to-day life. So it has to have a significant impact on your day-to-day function, or activities. It also can't be due to some other cause. So you might remember that from the definition of dementia, right? It's not dementia if it's due to something else, like a substance use or a medical illness. And I'll tell you which medical illnesses can look like depression or cause depression in a bit. As I mentioned, anxiety often goes along with depression. And some people have episodes of both depression and mania. So mania is where there is a period of being high. And so rather than being sad, sometimes people are euphoric, have a lot of energy, have a very decreased need for sleep, may have psychosis along with that or have delusions. So that if somebody has that as well as depression, then that might make us think more about bipolar illness. But for this video, we'll just focus on the depression part of things. Now, the other thing we look at is we go through this checklist usually called SIGI CAPS, and that's to look at other symptoms of depression. So SIGI CAPS is a mnemonic that doesn't really make a lot of sense, but it's easy to remember. So the S stands for a sleep disturbance, whether too little sleep or more sleep than usual. The I is for loss of interest. The G is for excessive guilt. E is for changes in energy, usually less energy. C is for poor concentration. A is for changes in appetite. P is psychomotor slowing. So somebody might actually be physically slowed down because of their depression, and I've seen that before, and it's usually quite striking. The other S is for suicidal thoughts, which is something we always have to think about, even in older adults. Older adults have a higher rate of attempted suicide than completed suicide compared to younger people. But older men actually are the demographic group that have the highest risk for suicide. So about 30 per 100,000 will have a completed suicide, and that's higher, as I say, than any other demographic group in the US. If someone is coming to see me with depressive symptoms, I often, I want to know about their other health conditions, because there are some health conditions that can either cause depression or can mimic the symptoms of depression. So those would be things like cancer. Certain types of cancer, particularly cancer of the pancreas, can produce depression. There could be a stroke, or after a stroke or heart attack, depression is more common. Parkinson's disease is often associated with depression, and dementia can be also. Dementia, actually, probably about 40% of people living with dementia have depression as well at some point. And sometimes the depression comes as the first symptom of the dementia. There are other things too, like thyroid disease, if your calcium level is very high, for example. So your doctor, if you go in to talk about your mood, they'll probably ask you some questions to kind of rule out some of those other conditions. And they might even want to do some blood work to make sure that it's not one of those other things that is causing the person to seem depressed. Now, a lot of medications can cause depression as well, or increase the risk for depression. So that could be things like benzodiazepines, which are downers. Also alcohol, which isn't a prescription medication, but it can definitely contribute to depression. It's a downer as well. There are things like Parkinson's medications, beta blockers, prednisone. They can all increase the risk for depression or have mood changes as a side effect. So that's another thing that a doctor or a nurse practitioner will probably want to review. As well as asking all of those questions, there are tools that we use to screen for depression. So like a lot of conditions, depression doesn't have a blood test or a scan that we can do to either rule it in or out. So we often use some questionnaires to help us. And the one that I use a lot is called the GDS, or Geriatric Depression Scale. This was developed about 40 years ago, and it still stands up today, and it's been validated in a lot of different settings. The Geriatric Depression Scale started out with 30 questions that asked about areas of mood and function. So whether or not a person had lost interest in things, had dropped their hobbies, was feeling anxious, hopeless, helpless, worthless, sad, those kinds of questions. The version that I use most often is the 15 question version, which has a cutoff of about 5 for depression. So if you answer 5 questions in a depression way, they're yes or no questions, so they don't take that long to ask. So if you answer 5 questions in a depressive mode, then that makes us think about depression, and so we might do some other screening to see if that's the case. There's even a 5-question version of the GDS, which has, if a person answers 2 questions in a depressive way, then that would make us think about depression. Even just asking the question, do you often feel sad or blue, has a fairly good sensitivity for depression. So asking those kinds of questions and doing those kinds of questionnaires, sometimes I find them a little awkward because they're a little bit repetitive. And oftentimes, even though we say it's a yes or no question, people will want to embellish or give more information when we ask them. But most of the time it works pretty well and it can be useful. When I think someone has a depression, I will often do some cognitive screening as well. The relationship between cognitive impairment and dementia is interesting, and it's a little bit complex. As I mentioned, sometimes depression can be the first sign of a dementia, and people who are living with dementia are at higher risk of developing a depression. It does seem that any history of depression can increase the risk of dementia, But an untreated depression can also make a person seem like they have dementia. There's a condition called pseudo dementia, which we usually use to refer to somebody with a depression that's severe enough to affect their cognitive function. And if you think about the symptoms of depression, you could see how they could affect thinking and cognition. So if somebody can't concentrate or isn't paying attention, then they might be more likely to forget something, or it might seem like they forget because the information just never really made it into the memory banks. So cognitive screening is something that might be part of a depression assessment, and it might be something that could be reassessed when the depression is treated to see if the thinking has improved. After the diagnosis of depression, it's time to talk about treatment, and that can take different forms. We'll talk about that in a subsequent video. Thanks so much for joining me today, and thanks for taking the time to learn more about depression in older adults. It's a pretty important topic because an untreated depression can lead to social isolation, it can make someone less likely to look after their other medical conditions, and it can increase the risk for suicide. So it's important to know about it and be able to detect it and get the person the help that they need. Please leave a comment below if there's anything that you have to share about depression in later life. I'd love it if you would subscribe to my channel here on YouTube and also follow me on my website, thewrinkle.ca. Thanks again for watching, and I'll see you next time.